Hi, I'm Sachin Goel. I'm the Medical Director for Structural Heart Interventions at Houston Methodist Hospital. Today I'm going to talk to you about degenerative mitral regurgitation and its treatment with mitral transcatheter edge-to-edge repair. Here are my disclosures. So we'll start with a case. Our patient is a 76-year-old female with paroxysmal atrial fibrillation, new onset severe mitral regurgitation, and heart failure symptoms. Medical history consists of hypertension, hypothyroidism, some questionable history of rheumatic fever. She's quite frail and weighs only about 100 pounds. She was felt to have poor rehab potential after open surgical mitral valve repair and as such deemed to be high surgical risk. And she was referred to us for evaluation of transcatheter options for mitral regurgitation. So here's her baseline echocardiogram, which was initially, she was seen at another hospital. And as you can see in the left two panels, the parasternal long axis with and without color, you can clearly see there is a posterior mitral leaflet flail with some suggestion of calcium in the posterior part of the valve and eccentric anteriorly directed jet of mitral regurgitation. The ejection fraction appears to be preserved. And on the right side, you can see a four-chamber view, again showing the posterior leaflet prolapse and flail, and a normal left ventricular ejection fraction. She was then referred by us for a transesophageal echocardiogram, which is the norm in these cases to evaluate the anatomy, and a comprehensive 3D TEE is usually required for this to assess the anatomy and suitability for mitral transcatheter edge-to-edge repair. So on the upper panel, you can see the intracommissural and the long axis views showing a big flail of the posterior leaflet with a wide flail gap and a flail width, and we'll talk about that in just a second. On the top right, you can see the 3D non-color image of the valve, looking at it from the surgeon's view from the left atrium, and as is labeled there is a prolapse and a flail in the posterior mitral leaflet in the P2 scallop region of the mitral valve. In the lower panel, you can see the corresponding color echo images, again showing very severe jet of mitral regurgitation that is eccentric and directed anteriorly as a result of the posterior prolapse, and the corresponding 3D color image on the bottom right. The mitral valve area at the leaflet tips was about 4.1 centimeters square. This is very important because there is always a risk of creating mitral stenosis, and we like to see a valve area of more than 4. And that really reduces the risk of creating severe mitral stenosis. And of course, on the right side, you see the systolic flow reversal by pulmonary vein Doppler, which also correlates with the severity of mitral regurgitation. The baseline mitral gradient is 3 millimeters of mercury, as you can see in the Doppler. So what are the options for this patient? Of course, surgical mitral repair, mitral edge-to-edge repair, transcatheter mitral valve replacement, and of course medical management. This patient was quite frail, weighing only 100 pounds, so the surgeon was worried about her rehab potential after open surgical repair, and her anatomy appears to be suitable for mitral transcatheter edge-to-edge repair with the current generation MitraClip devices. So just a little brief background on the MitraClip. The first MitraClip case in man was performed in 2003. The Everest trial was published in 2011 in the New England Journal of Medicine. We've obviously come a long way from the Everest. We have now several iterations of the MitraClip and also expanded indications. Based on the Everest trial, MitraClip was first approved in the United States for prohibitive surgical risk patients in 2013. And then, as you know, the COAP trial was published in 2018 for functional mitral regurgitation patients, followed by the FDA approval for functional or secondary mitral regurgitation in 2019. And then in 2020, the most recent valve guidelines update upgraded the 2B recommendation to a 2A recommendation for primary and secondary mitral regurgitation. And then there are ongoing and future studies, which we'll talk about briefly based on the latest generation of the MitraClips. Here's a slide showing the iterations. The initial Everest and the COAP trial were done with the older generations of MitraClip, and then now we have the fourth generation, which were released in 2019, and we have 4 different sizes based on the length of the MitraClip arms and the width of the device. As you can see, the NT, NTW, and XT, XTW. The N and the X refer to the length of the arms, and the W, of course, refers to the width of the MitraClip itself. So we have different devices to choose from. In addition, they also have independent grasping ability. Here is straight from the guidelines, the recommendations for primary mitral regurgitation. Once you have symptoms, then patients should be treated. If they are good surgical candidates or low or intermediate surgical risk candidates, they can have surgery. However, for high or prohibitive surgical risk patients, as you can see in the left part of this flow chart, the guidelines provide a 2A recommendation for mitral transcatheter edge-to-edge repair, as long as their anatomy is favorable for this procedure. So after looking at all these anatomic characteristics and looking at the patient's clinical situation, it was decided that she was a good candidate for mitral transcatheter edge-to-edge repair. So the procedure is performed under general anesthesia in the cath lab with TEE guidance. So here are the intraprocedural images. Again, you can see a big posterior leaflet prolapse and flail with an eccentric anteriorly directed jet of mitral regurgitation. The leaflets are pretty thickened, as you can see, and this is characteristic of degenerative mitral regurgitation. The left ventricular ejection fraction appears to be normal, and of course the left atrium is enlarged, as is often the case in these patients with severe mitral regurgitation. This slide demonstrates the concept of the flail gap and the flail width. The patient had a pretty broad flail and prolapse segment, as you can see in the intracommissural view, 1.3 centimeters, and the flail gap of 1 centimeter on the right side. This is important because the original trial, the Everest trial, excluded some of these patients with large flail gaps and flail widths. But now with the 4th generation Mitra clips, we are able to treat these patients very comfortably despite having a large gap and a large width. We also have independent grasping ability, which really enables us to treat a wide range of patients that we couldn't treat 10 years ago. Here's the baseline gradient of about 5 millimeters of mercury. This patient has a adequate valve area, and the gradient is often a reflection of the flow. This patient has torrential mitral regurgitation, and oftentimes we find that when they have such severe mitral regurgitation and the valve area is adequate, that after the procedure is done, the gradient actually comes down or remains the same without any significant increase in the gradient or development of stenosis, as you'll see in the subsequent slides. So here is the 3D echo image that I showed you earlier, and our procedural plan was to put 2 XTW Mitra clips in the A2P2 scallop regions of the mitral valve. And we chose these because the leaflet lengths were adequate. This was a wide flail gap and flail width, as I showed on the previous slide. So we thought that this patient would very likely need 2 clips to adequately achieve coaptation and reduce or eliminate mitral regurgitation. So this is a standard transeptal puncture. Again, this procedure, the success of this procedure is dependent on the imaging quality, and we have obviously excellent imaging here with Dr. Little and Dr. Faza as my interventional echocardiologists. And you can see the critical part is the location of the transeptal puncture, as you see on the left side. The echocardiographer is measuring the distance from the tenting in the intraatrial septum to the mitral valve. This height is typically 4 to 4.5 centimeters for an optimal Mitra clip procedure. And we use the echo to guide us to have this high and posterior puncture. In the middle panel, you can see the Mitra clip device system is advanced from the right atrium into the left atrium. And on the right side, you can see the 3D echo image where we are using the 3D to steer the Mitra clip down to the level of the mitral valve. And this really helps us look at the mitral valve just like a surgeon would intraoperatively from the left atrium. And we can steer this device medially or laterally or anterior or posteriorly depending on the orientation, and we can also rotate it to align it perpendicular to the line of coaptation. And the echocardiographer will tell us, okay, rotate clockwise or counterclockwise depending on the case. And in this case, we are aligned 12 o'clock to 6 o'clock, perpendicular to the line of coaptation, ready to grasp the anterior and the posterior leaflets. So here we are advancing the device, and you can see the corresponding intercommissural and long axis views on the left side, 2D images. We want to come in perpendicular to the A2P2, and on the right side you can see the 3D, which really nicely shows as we are crossing the valve, and you can see the orientation of the clip has not changed. It's still aligned 12 o'clock to 6 o'clock. So using the combination of 2D and 3D echo imaging, we can really cross the valve and stay perpendicular and line this up for success, as you will see in the subsequent slides. So here's the grasping. You can see on the top the valve is in the middle of the clip is in the middle of the valve, right in the A2P2 scallop region. And on the top right, you can see the anterior leaflet sitting nicely on the clip arm, and so is the posterior leaflet. and we are ready to drop the grippers and do the grasp. And you can see on the right bottom panel with the color, we've successfully eliminated the mitral regurgitation on the medial aspect, and there's still some residual regurgitation left on the lateral aspect, which we anticipated, and that was our plan to subsequently put a second clip. So here is the 3D with and without color image. We got a nice tissue bridge in the A2P2 scallops, and the mitral regurgitation in the medial aspect of the valve is gone, and there is a residual jet lateral to the clip, as you can see on the top right image, which is again eccentric, not surprisingly, because of the posterior flail, and it sort of hugs the anterior wall of the left atrium. On the bottom right, we see a gradient is down to 4 millimeters of mercury, so really the risk of creating mitral stenosis with a second clip is low in this case. Here is a second clip, again same technique using 2D and 3D. We are aligning the clip arms perpendicular to the line of coaptation, and we are exactly parallel to the first clip in the 3D view there, and you can see the corresponding intracommissural and long axis 2D echo images on the right side, and we are grasping the leaflets. The leaflets are pretty bulky, as you can see, but we've got both leaflets resting nicely on the clip arms on the rightmost image, and we are ready to grasp. And you'll see these images on the top left, the with and without color images. The second clip is perfectly positioned right next to the first clip. It's parallel. There is no residual mitral regurgitation there. And on the top right, you can see the 3D, again, a good tissue bridge, and the clip is parallel to the first one. And on the bottom right, you can see the color 3D imaging showing nice double orifice valve with 2 orifices on either side of the clips, with practically no mitral regurgitation, no residual MR. And in the bottom, you can see how this looks on fluoroscopy. The 2 clips are deployed there, and we are ready to withdraw the system and retrieve the delivery system safely. This is the hemodynamics. Before we do the clip, we always measure the left atrial pressure directly, and in this case, the V wave, as you can see, was 80 millimeters of mercury, so very, very high left atrial pressure, and the mean left atrial pressure was about 30, but the V wave was 80, and this patient was extremely symptomatic from this. And after we deployed those 2 clips, we again checked the left atrial pressure after the clips are deployed, and you can see a remarkable reduction in the V wave pressure in the left atrium down to 8 millimeters of mercury, with a mean left atrial pressure of about 6 millimeters of mercury. And this is very, very nice and very gratifying to see. When we see this, we know this patient is going to clinically feel a whole lot better, and she did. Next day, she was walking in the hallways and really noticed an immediate improvement in her symptoms. Concomitantly, the pulmonic vein Doppler, you can see the S wave is now no longer reversed. In fact, the S wave is dominant. We call this the resurrection of the upright systolic pulmonary vein flow. This is also a hemodynamic marker of successful clip procedure and clinical improvement. And on the right side, you can see the mean mitral gradient is 5 millimeters of mercury, which is what it was before we started doing the case. So really no evidence of mitral stenosis and a very acceptable mitral gradient at the end of the case. This is our discharge transthoracic echo. Again, you can see on the left the parasternal long axis with color. There is no residual mitral regurgitation. Ejection fraction is preserved. In the middle, you can see the short axis of the mitral valve with the 2 clips in the middle. And then on the right side, you can see the long axis 4-chamber with really no residual mitral regurgitation, and the clips nicely affixed to the valve. So this was a really good example of degenerative mitral regurgitation treated with MitraClip. So I'm going to talk for a couple minutes about the REPAIR MR trial. This is a trial that we are enrolling here at Houston Methodist. This is evaluating MitraClip in patients with primary or degenerative MR who are at moderate surgical risk and whose mitral valve has been deemed to be suitable for correction with surgery as well as MitraClip. And this is now expanding into the intermediate risk or the medium risk patients. As I mentioned before, according to the guidelines, the higher or prohibitive surgical risk patients have a 2A recommendation for MitraClip. But just like the TAVR studies were done in high-risk patients, followed by intermediate risk, followed by low risk, this is the next step in the evaluation of MitraClip in the medium or intermediate risk patients. There are going to be 500 patients enrolled in 75 sites in the United States, Canada, and Europe, and patients are being randomized 1-to-1 to MitraClip versus surgical mitral repair with the goal of a 10-year follow-up. Why is this important? Well, as you know, a minority of patients with severe mitral regurgitation undergo surgery. even when surgical treatment options are available. The MitraClip technology has really evolved since the Everest 2, which was more than 10 years ago now. There have been over 150,000, in fact now over 200,000 patients treated successfully with MitraClip, and it's obviously less invasive. And as you saw with the 4th generation MitraClip, we are able to treat a wide array of patients which we couldn't treat 10 years ago. There is no randomized trial looking at transcatheter therapy versus surgery. So this is the first such trial in this space, and really a paradigm shift based on this trial, if this trial is found to be positive. The scientific objective obviously is to compare MitraClip versus surgical repair in patients with grade 3 or greater mitral regurgitation, primary MR. Patients have to be 75 years or older, or moderate surgical risk, which we will define in the next slide. The valve has to be suitable for mitral repair as deemed by a surgeon, and also for MitraClip as deemed by the surgeon, interventional cardiologist, and the imaging team. So who are these moderate surgical risk patients? So if the patient is greater than or equal to 75 years of age, they are deemed to be moderate risk. If they are less than 75, then they need to have one of the following characteristics. Either they should have a STS score of 2% or more, or they need to have mild frailty with more than equal to 1 frailty factor, or more than equal to 1 major organ dysfunction, or procedure-specific impediments which would increase their risk. These are carefully assessed and considered for inclusion in the study. So this is very important. We talked about the inclusion criteria. That's sort of the cadence of the trial. 1-to-1 randomization, 500 patients randomized to the clip or surgery. The exclusion criteria are usual criteria for such trials. The main exclusion criteria are low EF, less than 30%, patients with severe mitral annular calcification, patients with renal insufficiency requiring dialysis. Patients who have concurrent coronary disease are not necessarily excluded as long as they have options for PCI as well as CABG, which is also incorporated in this trial. The endpoints are going to be a co-primary endpoint of all-cause mortality, stroke, cardiac hospitalization, or acute kidney injury requiring renal replacement at 2 years. And the second co-primary endpoint is a proportion of patients with moderate or less MR without mitral valve replacement and without recurrent intervention, either surgical or percutaneous, depending on the arm they are in, from the time of index procedure through 2 years. And there's a bunch of secondary endpoints. Again, patients will be followed out to 10 years. So in conclusion, mitral transcatheter edge-to-edge repair is a good option for high surgical risk patients with severe degenerative MR when their anatomy is suitable, and according to the latest guidelines, this is a Class 2A indication. I shared with you a successful case of P2 flail treated with 2 MitraClips. Imaging guidance, of course, is critical in the success of these cases, and Repair MR is an ongoing randomized trial for intermediate surgical risk patients, and these patients will be randomized to MitraClip versus surgical mitral valve repair. So if you have such patients, we'd be happy to evaluate these patients in our valve clinic. Thank you very much.